This is the phase 2 tiered care coordination pilot training presented today's date, December 14th, 2021. And the presenters will be Kimberly T. Lewis and Stacey Neumann. Okay, we want to go over the expectations for phase 2. As you guys have heard us say at our last touch point session, phase 2 of the pilot is going to begin on January 3rd, 2022. And phase 2 is going to be a little bit longer than the 3 months that we had for phase 1. It will continue for at least 1 full year. And so as we work with phase 2, we will be incorporating not only those new enrollees that we saw during phase 1 of the pilot, but we will also be incorporating those existing cases into the screening assessment tool. So just kind of bear that in mind. As far as your role as the care coordinator, that role is not going to change. We are expecting you to do all of those things that you currently do as care coordinators, just to make sure that our families are being served. But it's going to get a little sticky as we engage in phase 2, because what we will be doing is just looking at specific things related to your role as a care coordinator, how you manage your caseload, and then preparing for any new questions that arise as we try to understand the different expectations that come with phase 2. So how do you go about incorporating the tool into your existing caseloads? What you would need to do as care coordinators is just to be creative and look for those opportunities where you will have an opportunity to just review the information that's in your caseload. So an ideal time to look at completing the screening assessment tool would probably be during your plan of care update, because at that time you have a wealth of information. You're going over certain categories with the family at that time. So you would definitely need to utilize the plan of care updates as an opportunity to be able to look at incorporating the screening assessment tool with your families. Also, at clinic visits or after a clinic visit, when you're reviewing the clinic notes, that would be an ideal time to just kind of see about addressing the screening assessment tool. Right now at your 180-day contacts or caseload reviews, just when you have those opportunities to just kind of take a look at what's going on with your cases. And as always, updating when you're updating any annual paperwork, just making sure that you are engaging those opportunities to complete the screening assessment tool. So some helpful hints with the screening assessment tool. We would like for you guys to consider to establish a goal of how many screening assessments you will complete each week. For example, if you have a caseload size of 210, you will have to complete at least 4 assessments per week to meet your yearly goal. So just kind of keep that in mind. Look at your caseload size and then come up with an amount of assessments that you can complete that's going to be doable, that's not going to be too labor intensive for you, in order to be able to complete the required assessment tools within a year. Next slide. We ask that you spread out the number of assessments that you complete on the same date. As you remember, for when we rolled out the plan of care, for those who have been here a while and just remember that whole process, and if you have had any experience completing plans of care, you'll notice that the number that you complete on that one day are all going to come due 1 year from the date when you're completing the brand new assessments. So to prevent you guys from having to have so many due on the same date. Just spread it out. If you have 4 that are due on the 14th, just kind of spread out the assessments that you do during that entire week. So it won't be so labor intensive for you the next year when you are looking at completing the assessments. Also, use those tools that are already available to you, like the enrollment notes, the ROVs that you have completed within the last year on the family, and your plan of care updates to assist with scoring each category on the screening assessment tool. Next slide. We ask that you utilize the Excel spreadsheet to track the assessments that you have completed. That's going to be very, very important until the information is available in an electronic format. That's going to keep you guys on track as far as the assessments that you have completed, and then also those ones that you are needing to complete in order to meet your yearly goals. As a reminder, the tool is designed for internal use only. It is not meant to share with families. You do not have to inform the families that you are completing this assessment tool with them. This is something that is strictly for our care coordination activities at CRS. So just please keep that in mind, that the tool is to be completed independently independent of the family. Also, it's not meant for you to pull out and just use as a checklist as you're going through each of the categories. For example, don't go through each of the sections and ask the families, okay, what is going on with medical needs? What is going on with growth and development? We're asking that you utilize those comprehensive write-ups that you have as a part of the record to be able to complete the tool independent of the family. Also, please note that the tool is to be updated at least annually. However, if there are any significant changes that occur to the client or family situation, you can update the tool more frequently than that. Also, we're asking that you do not share the results of the screening assessment with the family, just keeping in mind that that screening assessment is for internal use only, to give you some ideas of how you are going to be able to serve those families that are in need of the most care through our program. Next slide.
Kim, may I say something real quick before we move on to the next slide? I just wanted to say that part of the pilot process, which Kim's going to go over the questions that are going to be part of the pilot in phase 2, but part of it is us learning your experience with the tool. So it's real important. I think that bullet on the screen about updating the tool, you must do it annually or as needed based upon significant changes. How you define significant changes in the client or family situation, is something you really want to watch and kind of, make notes of when you did updated the tool in those situations. And then we can discuss those different situations at the touch point session if you had any questions. But I really want you to remember that, it is a pilot, so it is a learning experience. So we want you to really, be mindful of all the experiences that you have while you're going through the process.
Okay. Thank you for that, Stacey. And just to add to the conversation that Stacey just mentioned, with your plan of care, remember, if you can think back to completing those, we give you the option of completing annually or more frequently if there are significant changes. So just kind of bear that in mind. We wanted to model what we're doing with the plan of care with the completion of the screening assessment tool. Okay, as far as the scoring range and follow-up, you will notice that depending on where the family falls within the tier levels, that's going to determine how often that client needs to have contact by the care coordinator. So when you are doing your overall scores, if a client falls into tier level 1, which is the minimal need, then you are expected to make contact at least every 365 days. Keep in mind, these are just minimal standards. The families can be contacted more frequently depending on what situations they have going on. But as a minimum, the client, if they're in tier level 1, they would be contacted every 365 days. If a client falls into the tier level 2, which is the moderate need category, then that client would have to be contacted at least every 180 days. And then finally, for clients that fall into tier level 3, which is the high need level, then that contact should be every 90 days by the care coordinator. As far as your responsibilities and results, we do recognize that the current R&Rs don't support the scoring ranges and the follow-up that I just shared as far as what we're trying to do with the pilot. So the pilot social workers, y'all should be aware that we are working to develop R&R specifically for the workers involved in the pilot for accountability purposes. And then also we are looking at making sure, the screening assessment tool should be scanned into case images upon completion. And we have noticed from some reviews of some of the newly enrolled cases that some of the screening assessment tools have not been scanned into case images. If you are experiencing any difficulties, please be sure to reach out to Stacey to let her know so that we can involve computer services in working out any particular issues that you are having. We were just a little surprised that we did not see more screening assessment tools already scanned into case images based on the number of enrollments that have been done. So I say all of that to say, just for accountability, just make sure that you guys know that we are developing some responsibilities and results. You will receive information on exactly what those new responsibilities and results will be as they are developed. So that you will be aware of what you will be rated on. And then also make sure that your clerical staff, if they have the responsibility of scanning in those screening assessment tools, just make sure that they are letting you know if they're experiencing any problems so that state office staff can work through those challenges as they arise. Next slide.
And just to, in addition to that, it's really important to build on what Kim said about them being scanned in, because we have, in those case reviews that Kim mentioned, it's really helped us to identify different areas of the tool that may be not clearly defined or may have some, questions. And it's just really helped our discussion at this level to say, hey, this may be an area of weakness in the tool because we have X number that are scoring it this way, and it could be because of this, but we really are looking at them. And so if the tool's not there, then we can't, look at the notes and compare it to the tool. So, and don't hesitate, like she said, to reach out and let me know.
Thank you, Stacey. As far as the screening assessment tool and charms, we are looking at having a page developed in Charms for the screening assessment tool, very similar to how you access your ROVs and your plans of care. So that is something that we will be working with computer services on. We're kind of limited as far as what we can do right now since this is a pilot, but we do have plans to have those kinks worked out before the tiered assessment screening tool goes statewide. Also, keeping in mind that we do need ways for the caseload activities to be tracked for care coordinators and supervisors. So what we would like to do is to have management reports devoted for the pilot. And then that way you can go in and be able to electronically see those screening assessment tools that you have completed, look at those that are coming due based on the date that they were last completed, and then also have those internal reminders as care coordinators of how to manage your caseload in regard to the screening assessment tool. So Stacey mentioned in the very beginning about phase one, and we are still going to be considering those questions that we utilize for phase one as we go through phase two. And if you remember, these are also questions that the staff at UAB went over with you as they were completing the focus groups with you. So as a reminder, we have these questions available on the screen. We're going to be looking at the time it takes to complete the tool, the ease of use, how well does the tool flow for you? Are the definitions and categories clearly defined, or do we need to make some tweaks there in order to make things more clear for you? Also, do the categories encompass what they need to encompass, just to make sure that we're all on the same page as far as what is expected for care coordinators. Also, we're going to be looking to see if there's any redundancy with the categories. Is the scoring accurate? Does it reflect the child and family needs? Are we able to show the progression from low, moderate to high? And is that logical for you? Also, does it show the differentiation, just that distinction from tier to tier? We think that's very, very important before it gets implemented. This whole pilot goes from pilot phase to implementation phase statewide. How easy is it for you to use the tool? And was that PDF that we developed, was that something that was helpful, or are there any changes that need to be made to that tool? And then finally, and most importantly, did it help you in your clinical decision making? Those things that you need to do as care coordinators with the use of this tool, how helpful was it for you to be able to plan those activities that are needed in order to assist the families in any issues that arise as you meet with them and talk with them during your day-to-day work with them? So some phase two questions that we came up with, they involve three things: your role as the care coordinator, your caseload management activities, and then also your family outcomes. But as you work through phase two and incorporating those existing cases into completing those assessment screening tools, remember to see if the tool supports you as the care coordinator in helping you to gather that relevant information about the child and the family. Also, is it helpful in helping you to build rapport with the families that you serve? We hope that with the existing cases, it will be easier for you to complete the tool because you already know the families. It's a little bit more difficult in establishing that rapport for somebody that's brand new. But for those of you who have completed the tool on some of your existing cases, and you have been very frank in sharing with Stacey and I just how easy it was for you to flow through the information because of the rapport that you've already established with the families. So that is something that we are expecting to see over time. Just also, is it helping you to follow up on the family's needs? Is it giving you that guidance and direction that you're seeking in order to be able to serve your families well? And that leads into the next question, just from utilizing that tool and your familiarity with the tool, is it helping you to be able to serve your families well? In terms of your caseload management, some questions to consider. Does the tool place families into the correct tier level? Also, with the scoring range that we currently have, does it place families, in your opinion, in the correct tier level? Is the tool helping you to prioritize your caseload? And then also with that, does the frequency of contact that I went over with you, how does that impact the cases that are in your caseload? Is that going to be something also, if you look at number 9, is that contact frequency manageable for your existing caseload? And then finally, again, we're looking at the categories and the definitions. Are they clearly defined in the tool? As far as the caseload management, I do want you guys to know that we don't have all of the answers. That's the purpose of this pilot. And so any information that we glean from you guys as the pilots, care coordinators, we would like to know just truthfully and honestly how well you are managing your caseloads. It's going to be a little bit more difficult when you are having to complete the tool on the newly enrolled cases, and then also to complete them on those cases that are currently already established on your caseload. And so it's going to be trial and error for you guys. I know that we have given you some helpful hints on how you can go in and complete those screening assessment tools on the existing cases, but pretty much you don't have to follow just what we have listed here. You can, if you find that there are other ways that you are able to glean that information and complete the tool, by all means, go on ahead and complete those. But for those who are struggling with how to be able to manage that responsibility, we wanted to give you those hints, just to put those kinds of things out there in the atmosphere so that you can use that if you don't have any other ideas as far as how to appropriately manage completing the tool on the existing cases. Okay, next slide. Oh,
Kim,
go ahead.
I have a couple questions. I have a question before we move forward. So I am a care coordinator and I was part of phase 1. I scored some tools in August, but at that time we were only scoring the tool. We weren't implementing the new contact frequency. So do I need, say in August, I had somebody that I scored as a high need, which I'm sure I've been talking to them because they had high needs. So I didn't, just go by the contact frequency. But can you elaborate a little bit about how to incorporate, to go backwards to those tools you've already scored and implement that contact frequency requirement?
Okay, thank you for that question. Since we are beginning phase 2 in January, those previous tools that you scored are not going to be, we're not going to be using that contact frequency for those tools. because with phase one, we were just looking at the tool itself. We were not looking at the contact frequency. And if you remember from our first trainings, we shared the contact frequency, but we did not want you guys to start contacting the families based on that frequency, because we were just only looking at the tool itself. So moving forward with phase two is when we will be holding the workers accountable for those screening assessment tools that they complete beginning January 3rd and onward. And that would be for those existing cases as well as for the newly enrolled cases. And we will be considering the contact frequency that I shared based on how the family scores in that tier level. Just we will be implementing those contact frequencies at that time. So I hope that answers your question.
Yeah, I didn't know if anybody might be thinking that, so I wanted to ask it. And just like Kim had mentioned, a big part of this phase of the pilot will be about caseload management. And we're also going to be talking to, or UAB will be speaking to district supervisors at the end, possibly during phase two, but there'll be a big focus at the end on the, looking backwards at the contact frequency and the caseload size and from the supervision aspect. So I just wanted to share that for the supervisors to know that that's something that's being looked at. It's going to be, discussed and analyzed before we take anything statewide.
Absolutely. Thank you for that, Stacey. So now is a part of the training where all of you guys can participate. I do see a question in the chat from Amber, or a comment that says that Huntsville is working to get the case images labels changed over, as most were not showing up prior to the last meeting when image issues were discussed. And all those prior have and had to be re-entered. Okay, so thank you for that comment, Amber, and just for that explanation for us. And as we said before, if you guys experience any issues with scanning the screening assessment tools into case images, feel free to reach out to Stacey, and she will work with Billy and computer services with working through those issues. Okay.
All right.
So Stacey, I'm going to turn it over to you.
Okay. So fingers crossed, everything works perfectly with the polls that we created. Kim and I are real excited about this part. We received a report from UAB on their focus groups that they did with you all during phase one. And so we really read those and looked at them and took everything that you all shared to heart. And so we've created an interactive training session. I'm going to launch our very first question. I'll read it, but you all can read it as well. A supervisor reviewing the enrollment write-up should not expect to see any correlation between the documentation and the tiered assessment screening tool. So the correct answer was false. The supervisor should be able to see that correlation between the documentation and the tiered assessment screening tool. And so that was when Kim mentioned doing case reviews. That's what she and I have been doing at the state level. And we really do, expect to see in that documentation a support for the score. And, there were some questions that we had. And again, it could be the interpretation of the categories or definitions. So that's why it's so important to be able, for you all to be able to share your thoughts and views on the way that tool is worded. So don't ever be hesitant to make a comment about this is confusing to me, or this is missing from that category, or where would I put this? That's why we're here, and that's what we really want to hear from you all. So, Kim?
Yes, and I would like to add, it's also going to be a big role for you guys that are supervisors as you're reviewing the enrollment write-ups and looking at the screening assessment tool. You have the task of supervisors of making sure that the information that's contained in the write-up supports the score that's on the screening assessment tool. Keeping in mind that how the family or how the care coordinator scores the tool is going to determine the minimum contacts. So you don't want to have just a bunch of clients falling into the tier level 1, which is minimal need. That means that the care coordinator only has the responsibility of contacting them every 365 days. We want to be able to show that correlation. We want to be able to support the score. And so as supervisors, nurse coordinators, and social work administrators who are on the call, just kind of keep that in mind, because that's an extra layer just to make sure that the workers are scoring the tool properly.
Okay, so I'm going to launch our second poll. Clients who are between the ages of 0 to 5 will automatically fall into the minimal need category when addressing educational vocational needs.
The correct answer for that one is going to be false. Clients that would be in the minimal need category, if we are looking at those ages, it should be from 0 to 3 years old rather than 0 to 5. So that's what makes that question false. So just make sure that you're paying close attention to the ages as well as the questions, because we try to make them real tricky for you guys, just to give you an option to think critically. And I do see that there's a question, are there going to be changes to the scoring levels? That, Amber, is something that we will be focusing on as we go through phase 2. We realized early on that some of the scoring levels may need to be adjusted. And so as we continue to do the touch point sessions to gather information from you guys, as we continue to have the focus groups conducted by UAB, that's something that we will definitely be looking at in terms of if those scoring ranges are accurate.
Thank you, Kim. All right, so now we're going to our next one. The tiered assessment screening tool should be used as a guide when conducting the enrollment interview with families.
That one is pretty close. I see 57%, and then what was it, 43% for that one?
It's 43%. Mm-hmm.
Okay, the answer to that one is true, but the way that it's worded, I was kind of looking at it, just seeing if there were some additional things that we needed to point out related to that. So for those of you who selected false, can you chime in and tell us why you selected false? No pressure.
Was it possibly the word guide? Because I know when we did the earlier portion of this training session, we had mentioned using the tool, and that you know it's internal use, and you wouldn't use it as a checklist. So it could be that word guide versus checklist, and they are a little like, you wouldn't go down it as a checklist, but you can use it as a guide to
select it.
Discussion.
Excuse me.
It was the word guide for me. It was the word guide for me.
Yeah, I selected false, and
yeah.
It was the word guide for me. Even though when I used it, I did use it as a tool for my enrollment, but I just thought it was just a good idea to use it. But I think it was the word guide.
For me, it was guide also, and it was during the interview, because y'all said earlier today, like during the interview, don't have it out. So it was a combination of both of those things that kind of had me like, okay.
Yeah, Thank you both for that.
Uh-huh.
'Cause as I was looking at it, I was like, well, that just kind of conflicted with what we had said. But you're right. You're not to use it as a checklist and going through each of the categories. But when you are meeting with the families, it's good to have the screening assessment tool somewhere so that you can make sure that as you interview the families, you are touching on those things that we don't ordinarily touch on when we're doing the enrollment write-ups. So you are familiar with what's being expected, but you're not just going through it as a checklist. So I think that guide word for that question was a little confusing. So thank you guys for that.
Yes, absolutely. Thank you for sharing. Question number 4. Care coordinators should assign a score of 0 or not applicable to categories that don't apply to the client family.
The correct answer for that one is going to be false. If you remember, each category has to have a score between 1 to 3. So there is not the ability for us to score a 0 or an NA. And for those categories that were problematic, like transition and educational vocational, if you remember, we put in a statement that says that this category may not be applicable because the client is between the ages of 0 to 3 for the educational vocational section. And then for the transition section, we put in a statement that the individuals that are not transition age will automatically fall into the minimal need category. So again, just making sure that you're paying close attention to the tool. And while I'm talking about the tool, we have had several revisions of the tool. Make sure that you are using the latest version of the tool. Whenever we have any updates, you will notice in the bottom right-hand corner, we'll have a revised date there. And that is to help you just to make sure that you're utilizing the most current version. Also, there may be changes in the verbiage, because we learned a lot from you guys during the touch point sessions and gathered that information and took it back to the local advisory group to let them know the information that we touched on during those sessions, and changes were made based on talking with that advisory group. So just a reminder, make sure you're using the latest version. And my revised version that I'm working from is dated
It's version 4.
11/5/2021 version 4.
And it was in the email reminder for the meeting, the most current version, and there were a couple changes noted. I tried to, when I send out the new version, I try to list the changes that were made. And so in our reminder email, if you didn't see it, it was sent this past Friday. And so you'll have the most current version. And if you don't hesitate. And I can also resend it out. I'll have notes in the slides from today's meeting and can send all that out at one time.
Thank you, Stacey.
Thank you for bringing that up. Okay, so our next question is, the assigned care coordinator is the only person who should complete the tiered screening assessment tool.
Okay, I see 79% said false, 21% said true. I'm curious to hear from you guys who voted false.
I voted false
your-
because I knew they said in some offices somebody else may enroll them. So I figured whoever was doing the enrollment would gather that information. even though it may not be who's going to be assigned as their care coordinator.
Okay, thank you for that, Amy.
And
And
the
I-
key word there was gather. You see what? Because
Gather.
this is the who should complete the actual scoring tool. Because Amy's right. Somebody else, it can gather the information.
Right, right. Somebody who voted true. Would you like to share with us why you voted true?
This is Kim Carter. I voted true because I just figured at the end of the day on your case, you are the one that will be doing it. I wasn't thinking of anybody else doing your enrollment, but just overall, as far as your old cases, as we do them with the plan of cares, it's going to be the care coordinator. That's why.
Okay, thank you, Kim. Well, the answer to that question, you guys, is true. And I go back to what Stacey said. Although some offices, there are other people who complete the enrollment, they can use that to gather the information that is related to the enrollment, but the responsibility of completing the tool is going to default to the assigned care coordinator. And that's why it's going to be very, very important if you're in an office setting where others do enrollments on cases that are in your caseload. You want to make sure that they are being as thorough and as comprehensive in their enrollment interviews and write-ups as possible, because you as the assigned care coordinator is going to have the responsibility of completing the tool. And Kim, you were right, just like with the plan of care, the plan of care can only be completed at this time by the assigned care coordinator. So we went with that same kind of model with the screening assessment tool. I noted that I said the plan of care currently. There are some revisions being made to the plan of care where it's not going to be where the care coordinator is the only person who completes the tool. And for those who are on the plan of care work group, you do know that we are going to allow other disciplines to be able to contribute to the plan of care. So just FYI for future. Okay.
I have a question.
Sure.
So moving forward, because I'm not sure if that's how we're doing it here in Huntsville. So moving forward, not the enrollment worker, the enrollment worker should not be the person to complete the plan, the risk assessment. You're saying the care coordinator needs to complete that.
Correct.
Wow.
Correct. It should be just the care coordinator who completes that assessment tool.
I have some questions about that as well, because previously when some of the questions in the tool, we have to use our own professional judgment on, and when, we've had these conversations before about it, things that just not fit. So if we're as the enrollment worker, are talking to the families and kind of using our own professional judgment, but then we're sending this information over to the care coordinator, don't you think that'd make it a little bit difficult for some of them to answer some of the questions?
We went with the same process, Keisha, that we used for the plan of care.
Mm-hmm.
That's why we say that the enrolling worker has to be as thorough as possible. As time goes on, if we feel through the pilot that is not the best way of getting that information, then we may need to take a look at allowing the enrolling worker to be the person who completes the tool. But as it stands for right now, that's the way that we developed it. If the assigned care coordinator needs additional information, they can, as they are contacting the families, gather additional information to be able to make the proper assessment and score the tool properly. But for right now, and what we're going to need your feedback on is whether or not that process is effective. So if you have been allowing the enrolling workers to complete the tool, we're going to ask that you stop that for right now. And we will measure just how that whole process is going as we continue through phase 2.
And let me elaborate, and Kim, because keep in mind, I may be speaking out of turn, so please tell me. But I noticed a lot. I looked at the tools and I looked at the notes, and if I saw something, say that there was, they got a score of 1, in which they indicated they didn't have a need in a certain area, and there was nothing to support it, then I had to assume that they didn't have that need. Does that make sense? And then, there actually were times that there may have been something documented in the notes that may not have been reflected on the tool. But if it's not, the key here is if it's not in the notes, then you just have to assume that they didn't have a need in that category or that area when you're scoring, unless, like Kim said, if you read something and you weren't sure about it, then you could approach the worker and ask for that input, or, when you're talking to the family again, to gain a little more insight. Because I saw some notes where the care coordinator would call the family and follow up with them, and you could gain more information at that time. But if it wasn't there and they got a 1, then I just felt like, well, that need wasn't there.
Exactly. I agree with that, but I'm just thinking, wouldn't that be a lot of kind of going back and forth? Like if something that needs to be explained, then you're going to find the care coordinator or the enrollment worker to try to figure out, well, what was said here versus having that family here and having that tool assessment, that tier assessment tool there. And while you're doing the enrollment, kind of going back to using that same tool to help guide, the word guide or whatever, in doing your enrollment. It doesn't seem like that'd be a lot of kind of confusion and back and forth.
I have just a comment. Keisha, think in terms of how you develop your plan of care. Because if someone enrolls that family on your behalf, and when you go in to complete the plan of care, you're going to be gathering information that may not necessarily be in the plan of care. You're going to be asking those appropriate follow-up questions, gathering that information that will allow you to complete that tool. And we're not just looking at the enrollment note itself to complete the tool. Remember, from the PowerPoint, we're looking at the plans of care, we're looking at ROVs for those existing cases, and then the enrollment note for a new case in order to be able to complete the screening assessment tool appropriately. So although somebody else will be completing the enrollment note, as the care coordinator, you're going to follow up with that family to complete the plan of care with them. And so that will be an opportunity for you to gather that relevant information that you need to score the tool, if that helps.
Okay, well, I'm just gonna agree, like with Felicia, just moving forward, I guess we would do it like that because we always didn't practice that here.
Okay.
Just keep that in mind.
Okay.
The biggest difficulty for the Huntsville office is that the way our caseloads are distributed is that the majority of the people that get the enrollments have an abundance of enrollments. So in order to kind of even out those duties, it was like whoever did the enrollment, go ahead and do the tiered assessment also. And the plan of care was left to the care coordinator, of course. But to just alleviate some of that additional stress for those enrollment workers who take the abundance of new enrollments, if it's in their caseload, they were doing it that way.
Okay. Thank you for that, Amber. And as we move forward, if there is an adjustment that needs to be made to that, then, we we'll certainly look at making those adjustments. But for right now, moving forward, we will expect that the assigned care coordinator be the only person who completes the screening assessment tool, regardless of who does the enrollment.
Well, not to share Jamia's business, but she has the most caseloads and she's about to be out for a extended period of time. So it will be someone else having to cover her.
Right. And are Jamia's cases going to be assigned to someone, or are you guys going to be just handling her caseload work through intake?
We're going to handle it through intake. I'm going to take the new ones, but all the ones that are already there, they're going to stay in her caseload until she's back. And then we'll just manage it through her caseload versus transferring everyone around.
Okay, so with Jamia's case, then if she's going to be out, then you guys can make some internal changes just that apply to her caseload, so she's not swamped when she comes back. You know what I'm saying? So if you're going to receive the majority of the caseload, then it will be on you to complete any of those screening assessment tools for those newly enrolled cases that come in while she's out. Okay, Stacey, do you have anything else you would like to add?
No, just that I've taken notes and we'll definitely keep this in mind, like you had mentioned, going forward. So let's do our final true false question. A client family must meet all descriptors in a tier level to be assigned to that tier for the specific category. We have a winner.
Yes, all of you, great job. The answer to that is false. And I think we have, just kind of beat that principle time and time again for you guys. A person does not have to meet all of those descriptors in order to be assigned that tier for the specific category. It's kind of an either or option. If they've got one thing going on, if they've got three things going on in that particular category, they would be assigned that just based on the verbiage that's there. So thank you very much. So we're going to take a 5-minute break.
Yeah, about 11:15, we'll start back.
Okay, 11:15, we'll start back, and you don't have to log off or anything like that. You can just turn your cameras off and we will see you shortly. Thank you.
All right, we are back. We are now back and we're going to move into our multiple choice question. It feels like we're taking finals before getting out for Christmas break.
It does.
Here is our first multiple choice question. Which one is not an automatic qualifier for the high need tier? And you should choose one option.
I see we have 83% who said the one that's not an automatic qualifier for the high need tier is the client who is a non-citizen, and that would be correct. If you remember at the tool, we've got certain situations identified as those that are automatically in the high need level, and those would be those clients, and let me read it specifically, those individuals in a detention facility, in a nursing home, or under DHR open case, safety plan, foster care automatically fall into the high need category. So a client who is a non-citizen does not meet those criteria and therefore would not fall into the high need category. Okay, Stacey.
I just want to bring this up just because from the focus group report, we did read and we have heard over what you all have expressed during the sessions with Kim and I during the touch point sessions about the concerns about DHR being in high need versus the scoring of the tool itself. And we did have a very internal discussion with our pilot team that consists of representatives from Children's Hospital, our CMC care coordinator in Mobile, and also individuals from Medicaid and our medical director and other CRS state office specialists. And it was just a long, intensive discussion that ultimately resulted in keeping that as the high risk indicator, just because there's so many variables that could go wrong very quickly. And Kim, if I remember correct, our medical director was very much in support in keeping that as an automatic qualifier. So I just wanted to say that we did hear you, and we did listen, but based on that advice and discussion that we got.
Yes, thank you for that, Stacey. And you were spot on. All of those variables that are associated with the DHR case can change very, very quickly. I know from what you guys have stated to us, those are the cases that are in stable situations. They have a case manager who is assigned to them. But we also know just from working with those cases at DHR, and for those who have been employed with DHR, that placements can become disrupted, very, very quickly. The case managers change. And because of the client's involvement with DHR, we felt that it's important that we do lay eyes on, those cases, that we keep in frequent contact with those cases, which was something that was co-signed by our medical director. Okay.
Okay. Our next one is, when completing the tiered assessment screening tool, the care coordinator should always do the following.
Okay, I think that's going to be it. So we've got 85% that says complete the tool independent of the family, and 15% that said none of the above. Would anyone care to chime in on why you selected either of those options?
I chose complete the tool independent of the family, just because you guys said that we shouldn't share it with the family, that it was for internal use.
Okay, thank you so much, Amy.
You're welcome.
Anybody else want to share?
All right.
Okay, well, Amy, you are correct. We have stressed that it is to be completed independent of the family. So C would have been the correct answer for that one. Okay.
Okay. A client with food insecurity is a factor when addressing the following categories: nutrition, growth and development, financial status and literacy, or community resources.
So that's a pretty interesting background. The majority of you chose community resources, followed by financial status and literacy. Third place was nutrition, and growth and development was fourth place. Would anybody care to chime in on why you selected what you selected before we reveal the answer? And just for a background, I think folks are a little hesitant to say what's what. We did throw in a trick question just to let you guys know that the verbiage in the tool may not reflect what you think it is. And so Stacey and I came up with this question as an option because in reviewing some of the enrollment write-ups and looking at the tool, we were trying to figure out why a care coordinator scored food insecurity in the financial status and literacy category versus community resources, nutrition, and growth and development. So the answer is financial status and literacy. Pay close attention to the verbiage in the tool. If you click on or look at the category for financial status and literacy, you will notice under the moderate area, that we have food insecurity listed there. All the way at the bottom, food insecurity is not listed in any of the other categories, except, we do have a category for food insecurity itself. But just looking at the choices, I would have selected, just me personally, community resources, just thinking of how broad community resources is. But when I go in to look at community resources, we're not asking specifically, or we do not state in the verbiage anywhere there about about food insecurity. So we put this in as a trick question just to make sure that you are paying attention to the verbiage that's there. So would anybody else like to chime in, or Stacey, do you want to elaborate?
Well, I will tell him about the mistake that I made. So in reviewing the cases, I had one and there was no mention of financial needs. So there were, but the financial status and literacy was a 2. And I kept thinking, I read over it, and I kept thinking, why, what am I missing? Am I missing something? So when Kim and I went over it together, I was like, Kim, what am I missing? And it was referral to a food bank. And so they had food insecurity, and I had just totally, in my head, and I had the tool and the notes side by side, and I had just, that didn't, I kind of skimmed over that food insecurity there. And so, oh, well, that's why they have a 2, because it specifically says food insecurity. And so that's kind of what led us to this question. And in my mind, it's not to say that the community resources couldn't be a 2, because they actually do need community resources to meet that financial food insecurity need as well. So
okay, thank you for that, Stacey.
The tiered assessment screening tool should be updated at least annually, every 6 months, if there is a significant change to the client or family situation, and then there's an option for both A and C.
The results, we have 7% who said at least annually. One person said at least annually. One person said if there is a significant change. And then 12 people said both A and C. And the correct answer for that would be A and C. We do state that on the tool. It's printed on there just for clarification that it should be updated at least annually, or if there is a significant change to the client or family situation. And that significance is going to be something that is subjective for you based on your interactions with the family. So the correct answer would be D, A, and C. Okay. And so, Stacey, if you will launch the last multiple choice question.
Okay, here we go. The tier levels on the screening assessment tool are
This was a little tricky because the order was a little reversed. But the correct categories would be A, high, minimal, moderate. If we were to order them in the correct order, it would be minimal, moderate, and high need levels. So just kind of pay attention. All of these questions were there to make sure that you're actually paying attention to the tool. Just the slightest oversight may impact the way that the information is interpreted. And so we put those questions there just to have you reference the tool and get familiar with the tool if you have not had a lot of exposure during phase 1 of the pilot. So now we're going to switch things up a little bit. And Stacey put on the agenda, which tier is it? we have some training scenarios that we want to discuss with you and continue to have just the interaction and the feedback from you on why you selected a certain tier. Keep in mind, you know, this is all for the purposes of training and discussion. And so do not feel shy in any way in disclosing why you selected what you selected, because that's going to give us information on maybe we need to, you know, adjust the definition. Maybe we need to flesh it out a little bit more. Maybe it is causing some confusion for the care coordinators. So just feel free to share your feedback as much as possible during this portion of the training. Okay, Stacey.
Okay. So you will read the description of, this is strictly on the, where this is a great time to have your tool out, because we had asked that you have a printed copy out. So for the medical needs category, if you read the client has no diagnosis but suspected autism due to no speech, lacks social interactions, and behavioral problems such as hitting and kicking, then what need or tier would you place them in? And again, like Kim said, this is to foster discussion. And
we've got 54% who say it was my tier level 2. And then an even split of 23% for tier level 1 and tier level 3. So I would be curious to know why you scored in the tier level that you selected. And as I said, there, you know, no judgments here. We are all just trying to understand how you've come to the conclusion of the tier level you would place this client in. And keep in mind, these are situations that you as a care coordinator may be exposed to when you are doing enrollment with the family, if you're working with the family. I can think of several situations as a care coordinator where I had a situation just like this to come across my desk. So if anybody cares to share, please do so.
This is a category that is, we see a lot of variation in this particular category. And so we really want to hear from you all to figure out, you know, what are we missing? What are the words, where, you know, where are there changes that need to be made? Anybody?
I will say that when we did the verbiage for the tiers, we looked at medical diagnosis, and we were under the assumption that everybody comes to us has a defined diagnosis. But we do have clients that come to us with chief complaints. And that's, Stacey mentioned the variation in the medical needs area. We were thinking, well, maybe we need to add language there that kind of addresses those chief complaints to see if that clears up some of the confusion that we're seeing in scoring for the medical needs category. So now's your chance to just kind of chime in if you would care to share why you selected what you selected.
I selected minimal, but I think it was the no diagnosis that made me unsure. So, I mean, if I could say he had autism, I would look more toward at least moderate. But I think I was looking more at the no diagnosis and thinking it was a trick question.
Okay, I got you. Thank you, Amy, for being so honest. So do you think with us having the discussion, Stacey and I, this is not something that's been presented to the advisory group. If we added in language in the verbiage for that category that says medical diagnosis or chief complaint for at least the minimal need and moderate need, but then leave high need as it stated, would that kind of help with the confusion that you were experiencing?
I think so, because I know especially like with orthopedic clinics, we do have a lot come in with just a chief complaint. So I do think that that would help.
Okay, thank you for that.
You're welcome.
Anybody else want to chime in?
And I just wanted to ask, well, thank you to Amy too for speaking. And I wanted to ask, is it because of how we had said you don't have to meet everything under the tool? So are you thinking autism? Well, they don't have a diagnosis, but that is something that could be stable, but an illness or crisis could exacerbate. Like, because I've seen them scored, this is a pretty real description here, and I've seen it scored both ways. And when I was talking to Kim about it, I was like, well, my mind goes to a 1 because they don't have a diagnosis yet. But if you're just looking at, one part of it, it could make you. So was that maybe why some people went a different direction?
I selected moderate, but I selected moderate based on the description of no speech. I didn't even think about not having a diagnosis. I don't know why, but I just selected moderate based off of, the severity of the behaviors is why I selected moderate.
I agree with her. If I think that the family is going to be calling back and they're going to need follow-up, I'm pretty much selecting moderate. When I'm doing minimum, I'm thinking 1 time a year it's going to be resolved. Those parents are not going to be okay just talking to somebody 1 time a year with all of those issues. They're still going to be calling back saying he's still not talking, he's still fighting, and more follow-up is going to be required. So that's why I went with moderate.
Well, that's why I went to high, because of serious developmental delays, said that he's not talking. So I was thinking more in those lines of, what he might need in therapy.
Thank you for that, Patricia. So we've gotten perspectives from the minimal, moderate, and high need category. I will call your attention, based on the advisory group, our meeting this month, actually, we did make some changes because there was concern that the condition is stable and usually stable needed to be reversed. So if you're looking at version 4 of the tool, you'll notice in the second part where we did try to show that progression from the condition is stable for minimal. And then as we progress to moderate, we'll show that the condition is usually stable, but then we did not make any changes to the high need category as far as the verbiage. And then also I want to point out, when we are doing this score, because this discussion came up too, it was, is there the variation because we're thinking in terms of what that client is going to need in the future? Or are we just taking into account what is going on at the present time? And so the consensus among our group is to focus on what is happening with that client at that particular time when you're scoring the tool. Now, the longer they're involved with our program, we know that we're going to do repeats of the tool annually, or if there's a significant change. But to cut down on some of the confusion, because we've seen that with medical needs too, it was our consensus to share with you guys just to focus on what is happening at that point in time that you're completing the tool. Stacey, do you have anything to add to that?
No, I think with the, changing the medical adding chief complaint, and then the changes you just described that we discussed as a team, I think will really help clarify some with the medical needs.
Okay.
Right.
All right. So like I said, this is just critical thinking exercise just to see where your heads are at in terms of the scoring. And it could be a 2 or a 3, depending on the presenting information that the client comes or the family comes to you with for the enrollment. So, okay.
All right. So this is for our growth and development category. Growth and development, premature infant, no concerns noted with development, but concerns with weight and feeding issues. And we're going across that growth and development line.
Okay, looks like the majority said tier level 2 at 62%, and minimal tier level 1, we've got 38%. Would anyone like to share why you selected what you selected?
I selected level 1 on both of the questions. Mostly because I feel like they would score higher in another domain, but not in the one that we're questioning. So like nutrition would be a higher score, but not necessarily growth and development, in my opinion.
Okay, thank you, Tarika.
I'll say I picked the moderate because the explanation was pretty clear. They're having trouble with their eating and there's some concerns with their weight. And anything beyond that would be a G2, more severe. So in my opinion, it would be clearly a moderate need. And the nutrition and the minimal would say no nutritional concerns unless there's an issue with development. But that was what I came up.
Okay, thank you so much for that, Mark.
I have a question.
Sure.
Because we're rating in specific categories, correct?
Wait, say that again for me,
We're
Teresa.
rating in specific categories. So this one is growth and development.
Correct.
And let me take both of what, you know, I think it's Tarika had said and Mark had said. So that when I would initially score this in my mind, a 1 for minimal and go down to the nutrition, you know, it would be more in the nutrition category. But Mark made a great point. You know, you could, if they're having trouble nutrition wise and there's concerns with weight and feeding issues, then that could you know, impact their growth. I mean, I mean, it's, yeah.
That is very, very good point. Very good point. How about one of our nurses chime in? How did you answer? Just out of curiosity.
I did put them on the moderate because I thought I wasn't sure, I was kind of guessing, but if they do continue to have the feeding issues, they may be referred out to something, even if it's feeding clinic or, you know, EI has to step in and help some. So that's what made me choose the moderate.
Okay. Thank you, Jennifer.
I chose the minimal just because based on just what's here right now. When it said they had no developmental concerns, they do have the weight and feeding issues, but I figured I would grade that in the nutrition category.
Right.
So as far as growth and development right now, I graded it a minimal.
Okay, thank y'all for that. And, you know, it's interesting that we're able to see these different points of view because you're going to be scoring this independent based on the information that is being presented to you. And so I see both sides, actually. I see scoring it minimally because you've got a whole section devoted to nutrition that you're going to touch on, you know, whatever issues, weight issues, feeding issues that they're having. But then you know that because of those weight and feeding issues, it's impacting their growth and development too. So it kind of places you in a quandary as the care coordinator on how to score in those different categories. But we did notice just through looking through some of the tools that a slight variation like that did not change the scoring level ironically. And that was something that, just kind of reinforced to us that we do need to take a look at those scoring ranges, because no matter if you scored it a 1 or a 2, it wasn't in the end going to be, that much of a change in the overall score. Stacey, you have anything to add?
Well, it just makes me see through the discussion that, that it is your professional, it's how you're interpreting the information, and that there really isn't a right or wrong answer. It is your professional, assessment of that situation at that moment in time. And part of what I think this exercise does, and what the previous one we did, is it just helps us expand to think, oh, well, just like Mark said, oh, well, they have weight issues. They could, in turn, that's going to lead to some growth issues. So I'm going to score them a moderate in growth and development as well, which I think is really, insightful. And so it's very interesting.
Yes, yes. And for the sake of time, because we surely have had a lot of good discussion based on, just these polling questions and things like that. What we can do is table, because we have a scenario for actually each category. And it'll take us probably until 1 o'clock to get through all of those, because the discussion has been wonderful. So, but we want to jump to a couple that were very, very confusing for us as we were reviewing. So Stacey, if you could jump to adaptive equipment.
All right. So this is in the adaptive equipment and accessibility category. A client with possible autism, but no official diagnosis, attends kindergarten, uses an iPad at school only, does not use any communication devices at home. No concerns with mobility, growth, and fine motor skills were noted. Okay, we are ready. We'll share the results.
Okay, 50% say tier 1, 43% say moderate, and 7% say high. So if anyone cares to share why you selected the tier that you selected for adaptive equipment and accessibility.
I'll just say, based on what little information I have, the only category mentioned as a concern would be the part about the assistive technology, the lack of communication. Everything else that was stated seems to be no issue. That was my opinion.
Okay, so Mark, you chose tier 1. Okay.
Yes.
Okay. All right. Anybody want to chime in on tier 2?
I chose 2 just because he has to use the iPad at school to assist him. I wasn't sure, but that made me choose 2 over 1.
Okay. All right. Thank you, Jennifer. Stacey, do you want to chime in just based on what you saw with the review that kind of brought this question to the forefront for us?
Well, now I am, now a question. Question that, when you read the write-up, I didn't consider the iPad. My question to Kim went, because I'm still, learning. And my question to Kim was, I went in the communication category. Like I didn't consider, I asked her, is an iPad, would that be considered in this particular category? So that's what started the discussion, because everything in me said communication. So I was like, well, maybe it's that scored the way it is because it's an iPad and it's considered, just like Amy, was that Amy? I think that Amy just said. So that's, yeah. But my initial in my mind, my initial score was a 1 because I put it all down in communication. I would have put it in communication, so.
Mm-hmm. And that's exactly the way that I felt with that particular scenario. I felt that adaptive equipment and accessibility was more so in terms of mobility is, I think is how I stated it to Stacey, rather than communication, since the communication has its own separate category. So if I were rating it, I would have rated it a tier level 1, but we put it here because on one of the tools, it was actually scored in a moderate level, and we were concerned if iPads, would you guys be of the opinion that that would be considered an adaptive equipment option rather than a physical mobility type option? And so that's why we put the question here, just to kind of get that feedback from you. If you had this scenario that was presented to you, how would you score it?
For me,
I do think I'm sorry, go ahead.
I'm sorry. I put it as a moderate because I look at it as the iPad as accessibility to communication and socialization at school. So not just, I mean, it's communication also, but that we're talking about accessibility and access to services, then that's where it would be higher.
Okay, thank you for that, Amber. Okay, Jennifer.
I was just going to say, I think as if I was doing an enrollment and I was looking through all of them at the same time, instead of the way we're going one by one, I might think of it more, oh, they're not talking about communication. They're talking, that as we're doing it one by one, I think I'm just thinking just for that specific area instead of thinking of what could come on down the line.
Okay. That's a good understanding, an explanation of why you're rationalizing it the way that it is, Jennifer. Thank you for that. And, when we talked about ADLs, because that is mentioned in the verbiage there, and accessibility, there again, it was another reason why we wanted to just kind of point that out, just to see how you would rate it if you were presented with that information. And so what this exercise has done is just kind of given us some guidance on if we need to take certain categories back to the advisory team to see if we need to make adjustments in the definitions. And so we have kind of developed a scenario, as I said, for each category. So during future touch point sessions, it may be something that Stacey covers with you, just so that we can continue this exercise of just kind of thinking critically and rationalizing why you came up with scoring things in the appropriate level. So what we're going to do is end the training exercise for right now, with the understanding that in future touch point sessions, y'all will get the opportunity to go through some of those other categories.
And the next steps will be, as everyone knows, Kim Lewis is retiring, and she will be greatly missed. And I have cried a lot. Her knowledge and the breadth of her knowledge is amazing. And so as we move forward, which we are going to continue move forward, I ask that you just work with me, and anything that you need that I'm not presenting to you, don't hesitate to say, we need this or I need this. But we will have the touch point sessions will continue, and I have not done the calendar invites because I want to complete this training and then send you the calendar invites, which I will do so you can block those off on your schedule. We will, there will be 3 UAB focus groups. Those dates are set. Those calendar invites will come from Lizzie, and she will do as she did similar to the past, give, I believe, 2 time options, or however UAB did it, to be able to accommodate everybody. But you might want to just do a little save the date, or I can do a save the date, but I don't have a time for those yet. Topics for future training. We did read in the focus groups that having the difficult conversations is something of interest to you all. Some of those categories, it's really difficult to ask somebody intrusive. You feel like if you're asking about their financial situation or, how they manage money, it can be a little bit intrusive. So we will hopefully plan more discussions around that. I envision a virtual training that we could do around the difficult conversations. And we want to develop tip sheets for each category. This won't be overnight because remember, we won't have Kim with us, but there is we know of another state that is working on tiered care coordination, and they're farther ahead than we are. And so we'll talk to them about seeing how they've done tip sheets and try to get some ideas and present the information to you all, and of course get your ideas, and because we want you to be have an active voice in this whole process, because it is a pilot, it is a learning opportunity. We brag on you all a lot at meetings and to the management team, that includes the other district supervisors, about all the work that you're doing and what the future looks like. And we just are so grateful that you take the time to spend on this and to talk with us. But that's what the future is looking like right now. Kim, did I miss anything?
No, I think you have covered it, Stacey. So if we could just stop the screen share and see all of these faces on the screen. I just want to say that I have just thoroughly enjoyed working with each and every one of you in this role as the care coordination program specialist and social work program specialist. Coming to the decision to retire was not something that was very easy for me, because if you notice in my email, I said that I struggled with the decision. I struggled with the decision to move from the district office to the state office, because I love the contact with the family so much and just those interactions. So I don't do well with change at all. But I am definitely going to miss just working with you guys and just all of the support and love that you have shown me. I'm trying not to cry, but I love CRS and I love the work that we do. And I just believe in our mission so much, because I see how the work that we have done has just really greatly changed the lives of the people that we serve. So I am counting on all of you to continue what we've started, and I will be in the background just cheering all of you on as you continue this amazing work. And just know that I'm your biggest fan, and I just won't say goodbye, but I will say see you later. And thank you so much for being a part of the pilot, and just all of your honest feedback and everything that you've done to make the first phase of this pilot successful. So thank you so much. And I pray that all of you have a wonderful holiday season and enjoy the time with your families. It is so, so, so precious. And Stacey's gonna be keeping me updated. She's got my number. She's gonna let me know what's going on with the pilot and just all of the wonderful work that you're doing. And I just hate that I'm not going to be able to see everything in its entirety completed, but I've been assured by the folks that are left here that they will continue the work that we have started. So thank you guys, and thank you for the amazing work that you do every day to serve our children and youth with special healthcare needs.
And y'all, thank you so much. We truly, truly appreciate you. And anything that you need, don't hesitate to contact me. And have a wonderful, wonderful holiday season. We're so grateful for all y'all. Thank you.
Okay. Thank you. Bye, everybody.